We'll start. So now my presentation, just a moment to see, for me to share the screen, please. Okay, there we are. So I am honored to participate in the Addiction Conference 2021 as a presenter in this online panel, which you can see it's titled, or the title is Substance Use Disorders Treatment Quality in the Americas. Of course, thanks to SANCA, thanks to the organizer committee and the incredible team that helps to make possible this virtual activity. Special thanks to Dr. Goodman Sibeko for his patience and dedication to coordinate this panel. Of course, thanks also to Jimena Kalawski, the CICAD's Demand Reduction Chief unit, because with her support, this is also possible, and her all the efforts that she has spearheaded for us to be here today. My appreciation goes to Adri, Marina, and Kyle, who have been instrumental in tuning all the technical details for us to be here this day. In today's panel, we will discuss the importance of quality of treatment of substance use disorders in the Americas, and also thanks to our interpreter who will be helping us to communicate efficiently in English and Spanish. As you know, globally, substance use disorders impose a heavy burden of disease, disability, and death, representing the loss of healthy life years, productivity, and well-being, and high social costs, among other issues. The recently approved 2020 CICAD Hemispheric Drug Strategy states that the world drug problem constitutes a global challenge that negatively affects public health, security, human rights, the environment, and well-being. It also undermines sustainable development, justice systems, political and economic stability, and democratic institutions, representing a threat to security, democracy, good governance, and the rule of law. In the Americas, the drug problem is an increasingly complex, dynamic, and multi-causal phenomenon that adversely affects multiple aspects of life. Responding to this problem requires a comprehensive, balanced, multidisciplinary, and evidence-based approach in full respect of human rights and fundamental freedoms, under the principle of common and shared responsibility, which considers the causes of the problem and includes demand reduction as a priority component. Demand reduction policies include essential elements, universal, selective, and indicated prevention, environmental prevention, health promotion, early intervention, treatment, care, rehabilitation, social integration, recovery, reducing adverse consequences, and related support services. Ideally, treatment services offer a range of comprehensive therapeutic intervention models that are evidence-based and follow internationally validated quality standards oriented toward treatment completion and sustained recovery. But what do we understand as treatment? Even though there is a definition by the World Health Organization, WHO, since 1996, it's not widespread. The WHO defines treatment as the process that begins when psychoactive substance users contact a health provider or other community service and may continue through a succession of specific interventions until the person reaches the highest attainable level of health and well-being. Treatment models must consider the needs of different populations, taking into account factors such as gender, age, socioeconomic context, community, culture, and other social determinants of health. These considerations are crucial from a gender perspective, According to the 2018 World Drug Report by UNODC, more men than women initiate drug use, but after initiation, women move faster than men towards drug use disorders. This phenomenon is known as telescoping and should define how to address specific treatment needs for substance use disorders within communities. But of course, as many of you know, this is still a big lack in the treatment services or to address the treatment needs of our communities. Although substance use is nowadays a significant cause of disability globally, few studies estimate the treatment coverage cross-nationally. An analysis of data published in 2017 from the World Mental Health Surveys found that among 70,880 participants, 2.6% met the 12-month criteria for substance use disorders. Of those affected by substance use disorders, 39.1% recognized a treatment need. Overall, only 7.1% of those with past year substance use disorders received minimally adequate treatment, meaning 4 sessions by professionals or 6 sessions by non-medically trained professionals. These data suggests that only a minority of people with substance use disorders receive even minimally adequate treatment. At least 3 barriers are involved in this process: awareness, perceived treatment need, accessing treatment once a need is recognized, and compliance to obtain adequate treatment. According to the World Drug Report 2021, published by UNODC, only 1 in 8 people with drug use disorders receive treatment each year. Cannabis use disorders are a significant source of treatment demands. From 2014 to 2019, nearly half of people treated in Africa, Oceania, and Hispanic America reported cannabis as a primary drug of concern or drug of impact. Treatment for drug use is still not tailored to the specific needs of women, just as we saw or just as we discussed because of the telescoping phenomenon. And there's still a significant gap in national capacities in many countries to provide evidence-based services as part of a public healthcare system. The 2021 World Drug Report findings reinforce what we found in our study, the drug problem in the Americas, which identified that treatment systems rely on a fragmented and segmented network with limited professionals. Additionally, the integration of treatment services for substance use disorders requires investment and specialized training, which of course are some components that make difficult this task of addressing integrally or comprehensively the world drug problem, particularly in the Americas. As many of you witnessed, current hemispheric challenges correspond to our study's findings, which the COVID-19 pandemic has intensified, such as crowded treatment centers, inadequate facilities and services, among many others. And you can see on the screen the typical pictures from most of the treatment centers that you have in mind, and most of the treatment centers which in reality are acting or operating more as refuges than treatment centers in general. To address this complex situation, and because of countries of the Americas define and apply in different ways the standards to allow treatment centers for people with drug problems to begin and continue operations, CICAD, jointly with PAHO, the Pan American Health Organization, developed the indispensable criteria for treatment centers And these criteria are also part of a larger publication or a complementary publication, supplementary publication that COPOLAD published in between 2014 and 2015. After this publication came out, we also involved the Caribbean region, which has been which had been working thoroughly to address these issues. And they also had developed their own criteria in the past. And of course, many of these criteria are nowadays aligned towards the same objectives. But still in the beginning, we had so many different efforts that not necessarily were streamlined or coordinated towards the same objectives. Nowadays, the situation is different, mainly because of the work we developed within these working groups that produced or published the criteria from CICAD and from COPOLAD and other institutions like UNODC that nowadays also are working with us to striving to get a better level of services and improve the quality of treatment available in the hemisphere. And of course, these criteria, the indispensable and the basic and advanced, share a common structure, which are the ones that you will see on the screen. And we divide the criteria in two large groups, which are structural and operations and processes. Or these criteria consider at least these two big areas for improving the quality of treatment and the quality of services. And through the pages of our documents, you will find all the details regarding all these different components that are described or that you can see on the screen, that are listed on the screen. And through those components, you will find different needs and requirements that treatment centers, services, and systems, but mostly treatment centers, need to comply with. So whenever we are interested in knowing how is a treatment center operating, we use these criteria to pay a visit to these facilities, which are providing services, clinical services, and we evaluate, we assess their operations using this type of criteria. Of course, this has been always in alignment with the local policies or the national policies coming from the national drug commissions. And of course, we use a lot this document. We use this information for us to have all the details that we want to discuss about improving the quality of services. If we want to have all those details handy and something for documenting our experience or our visits, that's where these criteria are useful or are handy for performing those processes. And we are not interested in punishing treatment centers, but instead we are interested in providing or flagging all the issues that treatment centers should identify to modify and improve in the future for doing this or complying with this continuous process for the optimization of the quality for their services. So thanks a lot for your attention. And this has been a great opportunity for me to describe the general perspective or an overview of what we are considering as part of the framework from which we need to start working, and all the components that or the main components that are currently available. And for sure, if we work together, as we have been doing with our partners and with our strategic partners, jointly working with CARICOM and with PAHO and many other agencies, we think in the future we will have an improved system, treatment systems in the countries of the Americas. Thanks a lot for your attention. And now we will continue with the other presentations. Please keep your questions for the final part of the session, where we will have a Q&A time. Thanks again. And go back to you, Andrea.
Thank you, Dr. Vázquez. Great presentation. Very important, the different factors that you highlighted and pointed out. We still face a lot of challenges in the region. We still do not have sufficient treatment centers. We're still working on the documents of what the basic requirements and the basic needs should be. Just a lot of very valuable information that you've mentioned. So please, we want the participants to send us your questions. And at the end of the 3 presentations, we will have some time to be able to respond to all your questions. Thank you again. Now we will go with the second presentation. And for the second presentation, we have Ms. Beverly Reynolds. She is a graduate of the University of the West Indies, Noma campus. She has more than 40 years of working experience in the fields of health, education, and adolescent and youth development, as well as social policy development at the national and regional levels. For the last 17 years, Ms. Reynolds has worked with CARICOM's Secretariat as a Senior Technical Officer in the following positions: Deputy Program Manager for the Health Sector, Program Manager for Sustainable Development, Officer in Charge for Health Sector Development and Coordinator, Health and Human Development. Ms. Reynolds has also headed and chaired the Secretariat's work in the area of trade-related intellectual property rights and access to medicines. Mrs. Reynolds, the floor is yours.
Thank you very much, and good morning to everyone. I wish to extend warm greetings on behalf of Ambassador Erwin LaRocque, Secretary General of CARICOM, and to express our appreciation to you, Dr. Goodman, Sibeko, for inviting us and allowing us to be a part of this conference. I also wish to express our appreciation to you, Dr. Jimena Kalawski, for including us, and of course to my good friends, to Jose Luis and Luis Alfonso. It's good to see you again. I would like to now share my screen, if I may. Just please tell me if you are seeing the screen.
We see the email you sent me,
okay.
Beverly. So you just close it, because you chose the option of sharing your full desktop.
Okay. I have saved it. 1 second. Is that okay? Are we seeing it?
Yes.
All right. Okay, thank you. So I just wanted to give a bit of a context and a background. The Caribbean community, CARICOM as we call it, was established by the Treaty of Chaguaras in 1973. And we are comprised of 15 full members and 5 associate states with a combined population of just under 15 million. And if you looking at the map here, you see that we're spread all over the Caribbean. Now that has importance and implications for us because it determines just how we operate as a region in terms of addressing joint problems, health problems, economic problems, and so on. So what's the history? About mid-2000, in the mid-2000, we had a proliferation of treatment facilities that were operated primarily by NGOs, faith-based organizations, and some private sector entities. However, what we found was that the whole matter of standards of care, quality, this was a challenge, and it was of particular concern to the community of demand reduction practitioners in the community. We had an assessment of the system that was in place, a regulatory system, but it was considered to be rudimentary. And at the time, in terms of standards of care and so on, we were really looking towards North America or the European standards, but we found those to be quite a bit of a challenge in terms of the implementation, given a number of differences in our societies. So, of course, as I mentioned earlier on, that because of how we are scattered across the region, because of our small size, one of the opportunities that we had under the Treaty of Chaguaras when we became a community was to pool our resources, and through functional cooperation, as we call it, both the financial resources, economic resources, technical resources were pooled to address common health problems, common economic problems. And in this time for us, as it relates to drug addiction or problematic use, both the heads of government, as well as the Council for Human and Social Development, the senior officials of the Legal Affairs Committee, all were of one mind as it relates to different aspects of this. That addiction is a chronic but treatable medical condition. The health of the region is a wealth of the region. And in the 2011 COSAD, 21st COSAD in 2011, the Ministers of Health mandated that the substance abuse should be addressed within the Caribbean Corporation for Health, and it should be looked at as a public health condition. Now, for the Caribbean community, standards of care must embody international compliance for safety and efficacy, but we also need something that's implementable, that can be regulated, that we can accredit, they can be accredited, again, given some of our unique situations. Because in the final analysis, what we're looking for is a streamlined approach for the delivery of the most effective services. Then and now, one of the major challenges that we've been faced with is the absence of official health policies and plans to inform and guide the design and application and evaluation of these treatment programs. So the journey began with CICAD, OAS, and PAHO when we looked at the common drug demand reduction criteria that they had developed. This was mid-2000. Then about 2011 or so, the CARICOM developed their standard of care, which was primarily for treatment. And then in 2018, under the 10th EDF cooperation program, our work with COPOLA 2 helped us to look at their model, which addressed common drug demand reduction indicators, as well as prevention and treatment indicators. So we undertook, during that period, we undertook the process of integrating the work by CICAD, OAS, PAHO, CARICOM, COPOLAD. And what we found was that working together, looking at these indicators and the standards, it helped to provide for us in the Caribbean a more comprehensive reach in the identified areas. It helped to foster a greater sense of regional ownership. And of course, among our member states, it promoted regional cooperation. One of the key activities that was undertaken was the review of the language for adaptation and of course, the validation exercise. These are the countries that once the indicators were prepared, there was a training workshop to again look at each indicator, the set of indicators, and then countries were invited, or CARICOM countries were invited to participate. And these are some of the countries. We had actually 7 countries participating, and the indicators were piloted in different areas: prevention, treatment, prevention and treatment in some countries, and so on. I just wanted to share that in terms of the in terms of the elements and scope that were looked at as it relates to the common drug demand reduction quality standards, structural criteria, and those are some of the scope that were measured, functional or process criteria, evaluation criteria. As it relates to prevention, functional criteria, and we have some of the subsets, evaluation criteria. Treatment, structural criteria, functional criteria. So the next couple of slides, you will see in terms of the piloting of the different quality indicators, the applicability, which refers to the fact that, yes, the indicators that and the criteria that were proposed, that were presented, were applicable in the countries. You can see we're having reasonable percentages indicating the applicability for the pilot prevention. The same thing for the common drug demand criteria for treatment. Very high reports of applicability. In terms of the applicability for prevention criteria, again, for the specific countries that the standards were piloted in, you're seeing that as well. Applicability for treatment criteria, similar. Similar in terms of high standards, high results were reported. In terms of implementation, however, we noticed some different things. So for instance, in countries where applicability might have been high, when it came on to implementation, there seemed to have been challenges. This related both to the common drug demand reduction prevention indicators, as well as the treatment elements. And you will know, for instance, in Jamaica, that was really quite low, but in terms of the applicability, we were seeing much higher standards. Prevention, measurable elements in terms of implementation, they were implementable. Again, we're seeing in one of our member states there where that was somewhat low. So this was a picture that came out of that. And I think this slide and the other one is important in that it indicates that as it relates to measurable elements, implementation, you notice the difference between implementation as compared with applicability. So where there was high level of applicability, there were challenges with implementation. Same thing was applicable for the common drug demand reduction criteria. Treatment, similar picture. Applicability, very high. Implementation, there were challenges. So a couple of the countries had the opportunity to, with additional funding, to really dig a bit deeper to find out what were some of the challenges. How is it that it's applicable? Some were already doing it, but when it came on to the implementation, there were challenges. And some of the results that we found was that there was either limited or no local legislation or policy addressing quality assurance for drug treatment centers, accreditation of programs, treatment centers, need for monitoring and evaluation system of the standards, absence sometimes of a database, limited resources, and to implement quality assurance system, or the lack of capacity in critical areas of need, such as dual diagnosis, de-escalation techniques, and so on. So in terms of the recommendations, and I have flagged what we think ought to be addressed at the national level and what ought to be addressed at the regional level. So we think all countries should have a national drug plan, which includes standard of care for drug treatment facilities. And it ought to, given the work that we've done, given what we've seen coming out of the piloting, we want to recommend that integrated system of quality indicators that came from the COPALAD, OAS, CARICOM, PAHO's intervention, that we are recommending very strongly that this is what our member states look at using. There is a need at the regional level to develop model legislation, which can then be adopted and adapted at the national level. Part of what this CARICOM Secretariat does, we have a legal general counsel's office with officers who do work with member states in developing model legislation. At the national level, we think it's important to identify and implement mechanisms for integrating quality standards into existing legislation and policy, to identify and engage appropriate accreditation bodies to create quality assurance system for drug treatment centers, and to build the capacity in critical areas of need, such as a dual diagnosis and so on. And important, I know a lot of time we talk about resources, human resources, or financial resources, but there are some things that even without some of these things in place, we can begin to do, which is, for instance, having operational manuals that will help to guide how centers work or what ought to be done. And of course, there's always the need for training and strengthening the service providers that we have in our countries as it relates to substance use and disorders. And with that, I would like to thank you for listening and stop sharing my screen.
Thank you very much, Ms. Reynolds. Excellent presentation. Very important what you highlighted, all the work that CARICOM is doing in the region, especially in regards to the prevention and treatment measurable elements and the difference between applicability versus implementation. And thank you very much, very detailed. And once again, we want to ask everybody that is participating in this session to send us your questions through the Q&A icon that is at the bottom of your screen. So thank you. And now we will go to the third presentation. Now we have Dr. Luis Alfonzo. He is from PAHO, and he is a Venezuelan psychiatrist who specializes in mental health, substance use, and epidemiology. He has more than 30 years of professional experience at a national and international level, covering the fields of clinical practice, academy, and public policies. He graduated from the Central University of Venezuela with a degree in medicine. Dr. Alfonzo occupied managerial positions in Venezuela in the Ministry of Health as head of the National Program for Prevention and Treatment of Drug and Alcohol Dependency. And he also was in charge of the National Coordination of the Mental Health Program. He served as an advisor on the drug treatment policies at the National Commission Against the Illegal Use of Drugs. And from 2006 to 2011, he served as a specialist in CICAD's demand reduction unit. Since 2011, he has been the regional advisor on substance abuse for the Pan American Health Organization. Dr. Luis Alfonso, the floor is yours.
Thank you, Andrea. I want to thank Dr. Goodman for the organization of this interesting conference in South Africa, and then Jimena Kalawski and José Luis Vázquez for inviting me in representation of PAHO to participate in this. I saw a lot of friendly faces and very known. I'm very happy to share with José Luis and my friend Beverly Reynolds in this panel. And I want to make a salutation to the friends from the other side of the Atlantic. I see many known people right there. So I will do my presentation on Spanish, and let's see. Okay. Do we have it?
Yes, we can see.
Okay. Ok, la presentación que me han solicitado acerca del tema de calidad de tratamiento para los trastornos por uso de sustancias en las Américas resume muchas de las cosas que ya han sido abordadas por el doctor Vázquez y por la colega Beverly Reynolds. Realmente el tema ha sido un tema muy presente en las discusiones políticas en los últimos 25, 30 años. Vamos a tratar de revisar algunas cosas, cómo lo miramos actualmente en la región de las Américas y cuáles son los desafíos que tenemos en relación con esta temática en nuestra región. En primer lugar, quiero enfatizar acerca de la importancia que para el ámbito de la salud tienen los trastornos por uso de sustancias. Cada vez estamos más convencidos de que la salud mental es un componente esencial para la salud y el bienestar y para el desarrollo socioeconómico. Es por ello que el acceso a los servicios de salud para la prevención y el tratamiento de los trastornos por uso de sustancias ha sido incluida dentro de las metas de la Agenda 2030 para el Desarrollo Sostenible. Es importante que esta inclusión se haya producido porque le da visibilidad a algo que solía pasar desapercibido. Asimismo, tenemos, sobre todo en este periodo de pandemia, la evidencia de cómo los estresores pueden inducir, pueden empeorar, pueden exacerbar el uso de sustancias y las complicaciones que se derivan del uso de sustancias. Esto incluye, por supuesto, los trastornos mentales preexistentes, pero también los que surgen como consecuencia de la situación de pandemia. Y también un elemento que es muy relevante para los que trabajamos en el ámbito de la salud mental, que es el riesgo de trastornos suicidas o de conducta suicida. Hemos insistido mucho en que la población con trastornos mentales, incluida la población afectada por trastornos por uso de sustancias, es una población altamente vulnerable durante y después de esta condición de pandemia por 2019. La región de las Américas es una región muy heterogénea y en ella coinciden muchas tendencias epidemiológicas de variada índole. Muchos países se ven enfrentados a una doble carga de enfermedad, tanto por las enfermedades transmisibles como por las enfermedades no transmisibles, incluidas los trastornos mentales, siendo las enfermedades no transmisibles, las principales causas de enfermedad, discapacidad y muerte en nuestra región. Los trastornos mentales y los trastornos por uso de sustancias dentro de este grupo de las enfermedades no transmisibles tienen una contribución significativa a esta carga de enfermedad, a este porcentaje de muerte prematura y discapacidad. Y aun cuando existen muchas intervenciones que son probadamente efectivas para reducir el impacto social y sanitario de estos trastornos por uso de sustancias, estos no son accesibles a todas las personas. La región de las Américas es probablemente la región más inequitativa del mundo y es muy posible que en la región de las Américas ese gap, esa brecha entre las personas que sufren sustancias y los que tienen acceso a los servicios pueda ser mayor que la relación 1:8 que aparece en el informe mundial de UNODC, informe mundial sobre droga. Ahora bien, cuando hablamos de respuestas sociales y de salud a los trastornos por uso de sustancias, el principal desafío que nos encontramos es cómo responder de manera efectiva a las necesidades de salud y sociales que se derivan de los trastornos por uso de sustancias, especialmente en esta contingencia de COVID-19 y ocurriendo también en otras crisis humanitarias, por ejemplo, la crisis migratoria, los desastres naturales. Para ello es fundamental el fortalecer la coordinación entre las diferentes intervenciones que se conocen como efectivas. Y esto a nivel nacional, a nivel regional o a nivel subregional incluso. Nos encontramos con el hecho de que muchas veces existen intervenciones que son potencialmente efectivas, pero que no existe un plan coordinado de cómo se van a ejecutar, lo cual les resta efectividad. El fenómeno de la fragmentación, de la desarticulación en la respuesta es uno de los elementos más serios que tenemos que enfrentar en el ámbito de la salud pública y de los servicios de salud para responder a los problemas por uso de sustancias. Por ello, es necesario e indispensable que podamos contar con un marco de políticas apropiado que nos permita abordar los trastornos por uso de sustancias y los problemas relacionados con estos trastornos desde una perspectiva de salud pública, de una perspectiva centrada en los sujetos, con una visión integradora y en un marco de protección de los derechos humanos. De allí que la propuesta que desde la OPS, desde PAHO, estamos haciendo para el abordaje de estos temas resida en un abordaje integrado. Integrado en primer lugar con las políticas de salud mental, pero también con las políticas generales de salud. Y sobre todo en un tema como, tan sensible como este, con las políticas de control de droga. En este trabajo y en ese sentido hemos venido cooperando muy de cerca con la CICAD en este abordaje. Es decir, cómo fortalecer la accesibilidad y la calidad de los servicios, de las intervenciones que desde el ámbito de la salud y que se ofrecen a la población afectada por los trastornos por uso de sustancias, especialmente aquellas que debieran brindarse desde la red formal de servicios de salud en los países. Para ello es importante el mejoramiento de las capacidades de estos servicios para que puedan responder de manera más efectiva a las diversas necesidades que se derivan de este tipo de problemas. Hemos encontrado un marco de referencia muy apropiado para este abordaje dentro de lo que hemos llamado la salud universal o el acceso universal a la salud. Dentro de los principios de salud universal están resumidos de alguna manera muchos de los elementos que debieran estar contemplados en una política de salud dirigida a la atención de los problemas por uso de drogas. Y esto mucho más evidente bajo la circunstancia de la pandemia del COVID. Como orientaciones específicas tenemos básicamente dos. En primer lugar, el fortalecimiento en los países de sus capacidades para la formulación de políticas que permitan el reconocer el abordaje de los trastornos por uso de sustancias de una manera integral, como parte de la salud universal que incluyan el enfoque de género y la protección de los derechos humanos. Esto debe ir acompañado de acciones de abogacía y también de diseminación de información apropiada y relevante en los diferentes sectores, tanto dentro de los ámbitos de gobierno como dentro de la sociedad civil. En segundo término, está el fortalecimiento de las capacidades del personal de los servicios de salud, a todos los niveles, no solamente a nivel especializado, sino a todos los niveles de la red de salud, poniendo énfasis en la atención primaria en salud, que permita mejorar el acceso y la calidad de las intervenciones de cuidado de la salud para los trastornos por uso de sustancias. Para ello, desde el ámbito regional, contamos con una serie de políticas que han sido asumidas por los Estados miembros en relación con el abordaje del uso de sustancias. En primer lugar, quiero referirme a la estrategia hemisférica sobre drogas y el plan de acción que es aprobado por la Organización de los Estados Americanos, pero fundamentalmente por la Comisión Interamericana para el Control del Abuso de Drogas, la CICAD. La Organización Panamericana de la Salud también aprobó una estrategia y un plan de acción que es armónico con esta estrategia hemisférica sobre drogas, en el cual se resumen los elementos básicos del abordaje de salud y social para los problemas por uso de sustancias. Absolutamente compatible con lo aprobado por los Estados miembros en la sesión especial de las Naciones Unidas dedicada al problema de las drogas, conocida como la UNGAS 2016, en la que se hacen una serie de recomendaciones operacionales que aluden directamente al rol que debe jugar el sector salud o las organizaciones de salud para el abordaje de estas sustancias. Ahí se le da mucha relevancia a la integración de los cuidados a la red formal de servicios de salud, pero también al uso de estándares para el aseguramiento de la calidad de los servicios que reciben los usuarios. En este sentido, contamos en la región de las Américas con valiosos socios estratégicos. En primer lugar, por supuesto, la CICAD OEA, con quien tenemos una estrecha relación de trabajo desde hace muchísimos años, pero que se ha venido reforzando durante los últimos 2 años de manera notable. También la relación con la Oficina de Naciones Unidas contra la Droga y el Delito, UNODC, quien elaboró conjuntamente con la Organización Mundial de la Salud los estándares internacionales de tratamiento que han sido validados en campo y que están siendo en este momento puestos a la disposición de los países para su implementación. Pero no podemos dejar de lado un elemento que para la región de las Américas es muy importante, que es el sector de la sociedad civil. Y allí contamos con valiosos aliados como la Red Iberoamericana de Organizaciones que Trabajan en Drogas, que es una red de organizaciones no gubernamentales que viene apoyando al principal proveedor de servicios para personas con trastornos por uso de sustancias en las Américas, que son las organizaciones no gubernamentales. En las Américas, y con esto quisiera un poco resumir cuál ha sido la historia en los últimos 20, 25 años en relación con los temas de estándares de tratamiento en las Américas. Hemos tenido abordajes de tipo regional, que abordan toda la región. Allí ha sido clave y fundamental la alianza entre CICAD y OPS, a los años 2000 para el desarrollo de lo que llamamos en aquel entonces los estándares mínimos de tratamiento, que sirvieron de base para los estándares subregionales que se desarrollaron en CARICOM. Tenemos también a nivel nacional diversas metodologías y resultados, países que han utilizado estos estándares como referencia o que han hecho un trabajo por sí mismos. A nivel global ha habido también interesantes desarrollos, algunos de ellos en paralelo y otros de manera sucesiva, como es el caso de los estándares que se elaboraron para el proyecto TreatNet de UNODC, los estándares internacionales de tratamiento que traducen en la práctica lo que fueron los principios básicos de tratamiento también desarrollados conjuntamente por UNODC y la OMS. Pero hay otros documentos que, si bien no se hicieron directamente para ser utilizados por organizaciones que trabajan con trastornos por uso de sustancias, sino para salud mental, incluyen una serie de consideraciones que son básicas, como es el caso de los Quality Rights, todo el paquete de Quality Rights en relación a protección de derechos humanos de las personas con trastornos mentales, incluidos trastornos por uso de sustancias. Algunas iniciativas independientes como el aseguramiento de calidad por parte de la Federación Latinoamericana de Comunidades Terapéuticas, el trabajo de la RIOT que ya señalé, y algunos más recientes, como es el caso del International Society of Substance Use Professionals, de ISO, que ha venido también apoyando en sus acciones con los Estados miembros el tema de calidad como un tema relevante para el mejoramiento de la situación problemática. Contamos en este momento con una coyuntura muy favorable, es decir, hay una decidida vocación de trabajo interagencia. Esto finalmente lo pudimos concretar en Washington, D.C., en la sede de la OPS los días 11 y 12 de octubre del año 2018, donde se realizó la primera reunión interagencial para coordinar la cooperación técnica en relación con estándares de tratamiento de drogas. Allí participaron la UNODC, WHO, OPS, el proyecto COPOLAT de cooperación entre la Unión Europea y los países de las Américas, por supuesto la CICAD-OEA, el Observatorio Europeo sobre Drogas y algunas iniciativas más específicas, como el caso de la Senda Chile o el Colombo Plan o los donantes como INLUs. Estas reuniones, digo estas reuniones porque esta fue la primera reunión, han sido seguidas con sucesivas reuniones preparadas en esta ocasión por CICAD fundamentalmente, en la cual los temas, como mencionaba José Luis Vázquez anteriormente, se han seguido trabajando. Siguen pendientes algunos desafíos en relación con esto. En primer lugar, la generación de un marco técnico y político en el cual se pueda orientar todas estas intervenciones relacionadas con el aseguramiento de calidad, la definición de un plan para el desarrollo de estos estándares de calidad, y esto sobre todo a nivel local, es decir, definir tareas, definir quiénes conducen el proceso, decidir los recursos, es decir, cómo se implementan, lo que decía Beverly Reynolds hace un momento, es decir, cómo estos elementos pueden ser llevados a la práctica y no pasan de ser una manifestación de buenas intenciones. Esto implica cómo articular las propuestas relacionadas con la calidad con la organización de los recursos de atención en los diferentes niveles de complejidad, porque el tema de calidad no es única y exclusivo de aquellos establecimientos especializados en el tratamiento, sino que de alguna manera es transversal a todos los niveles de la red de servicios de salud. Con esto quería resumir mi intervención y quedo atento a las dudas de los participantes. Muchas gracias.
Thank you very much, Dr. Alfonso. That was a great presentation. And thank you for emphasizing on how to effectively respond to substance use disorders. And you've mentioned a couple of different components there, such as strengthening coordination, appropriate policy framework, and also an integrated approach among the different agencies. Thank you for also talking about all the work that we've been doing closely between CICAD, UNODC, and all the other international organizations such as CARICOM as well. Very detailed and informative. Okay, so thank you. We've concluded the three presentations. Now we will start with the Q&A session. And I will now pass the floor. Can you say, like, I will pass the floor to José Luis. José Luis, please, if we can start with the Q&A session. Thank you.
Thank you. Thanks a lot, Andrea. Muchas gracias. Thanks, of course, to Beverly and Dr. Luis Alfonso, because this has been very informative. And again, thanks to SANCA and all the organizers, because this session is only possible thanks to you. And we are happy to be here together discussing this important topic. Some of you have already asked some questions, and I've been answering those questions on the Q&A box, through the Q&A box. So if you go there, you will see the answers because those of them are public. I see a question on the, or a better say, a comment on the chat from Carlos Natividad, which is in Spanish. I think it has to do more with what Luis Alfonso mentioned. I don't know, Luis Alfonso, if you are able to see that question on the chat from Carlos Natividad, or if you want me to read it.
Let me see.
On the chat, not on the Q&A.
In the chat?
In the chat, it says, en relación al acceso a salud universal, muchos de los planes de aseguramiento en salud no contemplan, ya lo viste ahí, no contemplan tratamiento.
Definitivamente eso es una realidad y que no tiene una justificación, en el sentido de que las enfermedades mentales y las enfermedades por uso de sustancias son enfermedades y debieran ser cubiertas por los sistemas de aseguramiento de calidad. En ocasiones hemos encontrado cómo en algunos países se da la circunstancia de que si una persona tiene un accidente bajo los efectos de una sustancia, bajo la intoxicación, las pólizas no cubren de manera total lo como llaman los aseguradores el siniestro. Eso es una violación de los derechos de la persona. Es decir, cuando asumimos que la persona tiene una enfermedad, es una enfermedad. La adicción no es una enfermedad voluntaria. Es una enfermedad que se produce como consecuencia de un factor de riesgo. Por lo tanto, sigue habiendo todavía un tema enorme de desigualdad y de segregación. Por eso es que el tema va más allá de una propuesta técnica, va una propuesta que tiene que tener en consideración la salud como derecho y el acceso a los servicios de salud a toda aquella persona que los necesite sin que ello comprometa para nada el futuro de la persona. Es como una analogía con lo que nos planteamos muchas veces como desarrollo sostenible, es decir, cómo nosotros respondemos a las necesidades actuales sin comprometer el futuro de las poblaciones. En esencia, salud universal o el acceso universal a la salud implica el poder tener los servicios que se necesitan sin que eso comprometa el bienestar de la persona que sufre la enfermedad.
Muy bien, muchas gracias. Thanks a lot, Dr. Luis Alfonso. And someone who has been very active with 3 questions up to now, because maybe he has more, is our good friend Javier Córdoba, who many of you know because of his extensive background on working on this field. And Javier is making a third question that I think maybe Beverly has some information about it. Beverly, I'm not sure if you are able to look at the question on the Q&A box, or if not, I can read it to you.
Please go ahead and read it. I am looking, but I'm not seeing it.
Yeah, so Javier asks, in reference to COVID and substance use disorders, do CICAD or PAHO, or in this case, CARICOM, have recent data showing increase of substance use, alcohol, cannabis, or legal drugs in the Hispanic American Caribbean regions or nations? Do you have any information in this regard?
Okay, so what I'm aware of is that there are a couple of our member states that have done, undertaken studies to that effect. I think Grenada is one of the countries. I am not quite sure about the others, but anecdotal reports seem to suggest that there is an increase, and in particular, the marijuana use. And well, you know, for us in the region, there is that additional concern, because what has been happening is that there's been a reallocating and a shifting of resources from some of our other key health programs, for instance, NCDs, non-communicable diseases, as well as substance use programs, as well as HIV and AIDS, towards the COVID-19 response. And also the reports that we've been getting is that even with the treatment facilities, there has been that kind of down grading in terms of the ability to keep them, you know, vibrant and open. So the anecdotal report seems to suggest that there is, but we're also looking at the other implications, both from the ability to provide services, to continue services, and then of course to provide services on platforms that many of our clients might not necessarily be able to access, right? Because we are in some instances quite strapped technologically to provide the services.
Yeah. Thanks a lot, Beverly. I don't know, Luis Alfonso, if you want to add anything, and later I can add some information from our observatory and other reports. Luis, do you have anything you would like to add regarding substance use during the COVID-19 pandemic?
No, lo único que tenemos al respecto es que si bien es cierto que puede haber una disminución inicial como consecuencia de la distorsión de los mecanismos de distribución del mercado ilícito, no hay una información suficiente, porque los mecanismos para la recolección de información han sido bastante complicados. Usualmente lo son, pero han sido bastante complicados. Sí tenemos evidencia, por ejemplo, en el caso de la industria de alcohol, que ha utilizado mecanismos para tratar de incrementar sus ventas a domicilio o las ventas a través de la internet, pero no hay una información sistemática suficiente como para poder indicar qué es lo que hasta este momento ha definitivamente ocurrido. Sí va a haber, hay alguna gente que está recogiendo información. Sé, como decía, el Observatorio Interamericano está haciendo algunas evaluaciones, y en el ámbito de alcohol, desde OPS también se han estado tratando de recoger información. Pero no es simple, digamos, algo complejo, y sobre todo mucho más complejo en las circunstancias de restricciones que establece la respuesta a la pandemia.
Thanks, Luis. And I want to add that some of the complexity is because of the not so quick methodologies that we currently have for gathering information, epidemiological information. Dr. Maristela Monteiro and her team, as Luis mentioned, put together and were able to implement a quick survey on alcohol use during the COVID-19 pandemic. And it showed different patterns. And of course, because of the level of confidence of the information and because of the methodology applied, and it's very complicated to make sure that you have answers corresponding to only one person and all the details, socio-demographic details because of the confidentiality and the limited access to internet in many countries complicate all these. But with that said, or considering those caveats, the information coming from those reports shows that there has been like a diverse pattern of consumption, which in many cases, depending on the substance and its availability, it has increased. And in some regions where substances are not as available because of the pandemic as before, well, those substances have registered at least a short-term decrease, but not it's not homogeneous throughout all the age groups. It's not homogeneous in all the different subgroups of these period or the population. So that's why we need to take any information, as we would say in Spanish, con pinzas, take all this information to be with a lot of limits and caveats, limitations and caveats, because this information is still something, a work in progress. It's still something unfolding. And if you think about, for example, the World Drug Report that is produced with information from 1 or 2 years before, you know that all this epidemiological information has to be very well analyzed and has to be gathered and goes through a complex process that takes some time. Even the information regarding vaccination, for example, and the clinical trials, you've seen that this is a complex situation that unfortunately we don't have as quickly as we would like to have the information available nowadays. So I hope this provides some detail. And of course, as I said, the observatory, the CICAD observatory has been also gathering some information that in the future will be a part of some other publications. And the World Drug Report shows us that depending on the substance, the pattern has been different or having a different behavior. And I see Javier has another comment, but Luis Alfonso is addressing it, typing a response. I see many thanks and nice comments, flattering comments to all of us as panelists, congratulating Beverly and Luis Alfonso. Yeah, Beverly, you want to say something? You are muted. There you are. There you are. Yeah.
No, I'm sorry. I don't know how my hand went up.
Oh, okay. You have your, don't worry. Don't worry. Yeah, I see everyone saying thanks for these presentations, which have been informative. Thanks, of course, to Rochelle, Maria Natividad, Mohammed, Professor Dr. Kamal, Carlos Natividad, and many others who are sharing comments and providing flattering comments to our presentations. Angela, also thanks a lot. And well, I think we have covered many of the comments and questions from our participants. If we may have some other final comments from our panelists, and then we will have the final words from Andrea Escobar. So please, Beverly, a final message.
Thank you. So I think what I would want to do really too is to reinforce the need for the structures to be in place to support the implementation of these quality indicators. And I wanted to just say, as it relates to what Luis Alfonso presented, this thing of the impact, the mental health impact of COVID-19 on persons, especially who are having problematic challenges with drugs. It really is something that I think we need to address urgently. I am very happy to see some of the recommendations that he has put forward, especially because today we are currently right now having our biennial meeting with the UN. And among the things that we look for are areas where we can strengthen our collaboration and our cooperation. And I'm pretty sure that PAHO would be in that meeting. So I will be reaching out to you, Luis Alfonso. Thank you. And thank you for allowing us from CARICOM to be a part of this social release. Thank you. Thank you to all the others too who have organized this. Thanks.
Thank you, Beverly. Thank you very much for your participation. Thank you, Jose Luis, for all the work and your presentation, Luis Alfonso. So basically, once again, I wanted to thank SANCA and all the coordinating committee. We've been meeting very frequently over a period of over 6 months to put this conference together. And we really appreciate the fact that SANCA allowed CICAD to participate in this conference, to allow all the participants to understand better what is going on in our region, in the Americas. So basically, what we want to do from now on is continue working closely with Africa. This collaboration among the two regions is very important for CICAD. We are really trying to promote and to continue working very closely with the African Union through a global dialogue. And we also had the opportunity to receive some financial support from INL USA to be able to continue collaborating in this initiative. We've been able to see great results so far. The relationship between both regions has strengthened drastically in the last couple of years. So thank you again for allowing us to participate. Thank you to all the panelists. Thank you, Dr. Alfonso. Thank you, Beverly. Thank you, Jose Luis. And tomorrow we will be having the second session. We will be having another panel discussion. So we hope that everybody can join us. And thank you to everybody that participated today. We greatly appreciate all the questions that you have. If you have any further questions, please let us know and contact us. So thank you. And we've gotten to the end. Thank you very much.
Thank you. Thanks. I think we still are missing a final message from Luis Alfonso and mine, because I thought it was going to be Beverly, Luis Alfonso, me, and then you. But doesn't matter.
Okay.
So
okay, go. I'm sorry, then go ahead.
Has something to say. And just to tell everyone, tomorrow's panel will also be with interpretation between English and Spanish. I already posted the link for registering on the chat. And then, Luis Alfonso, please, your final thoughts.
En primer lugar, agradecer la invitación y haber incluido este tema entre las diferentes tópicos que se están tratando en esta conferencia. El tema de calidad está muy vinculado en el caso de los trastornos por uso de sustancias al tema del estigma y de la segregación, en el sentido de que no es aceptable que para un tema tan grave como el tema de los trastornos por uso de sustancias y otros trastornos mentales se admitan como válidas aproximaciones que no son permitibles en ningún otro problema de salud. Lo mínimo que requiere o que merece recibir una persona con un trastorno por uso de sustancia es la misma calidad de atención que se le da a cualquier otra enfermedad. Es decir, desde allí es que debiéramos partir. Entonces, el asumir, el desarrollar estándares de acreditación implica también el asumir la responsabilidad de corregir aquellos elementos que ponen en peligro ese aseguramiento de calidad. No solamente aprobar normas, aprobar estándares, sino también invertir en proveer el mejor tratamiento posible para las personas que tienen un problema tan grave como este. Pero bueno, seguiremos discutiendo. Yo creo que es un tema que no se agotó aquí. Muchísimas gracias y nos vemos mañana.
Excelente, muchas gracias Luis Alfonso. Bueno, yo solamente al final también un poco en español para variarle. y bueno, comentar que muy agradecido con todos los organizadores. Muchísimas gracias a SANCA por la oportunidad de estar, de formar parte de esta conferencia 2021, que es todo un reto hacerlo online. Así que para nosotros es verdaderamente un lujo poder participar y traer a la realidad, a este espacio la realidad que nosotros vemos como organismos internacionales, agencias regionales, la realidad de las Américas, de los países de las Américas, donde ya lo dijimos nosotros durante las presentaciones, la situación es que hay una necesidad muy importante de atender esta problemática con metodologías basadas en la evidencia, de eficacia probada, que además ya están disponibles y que en muchos países existen, pero que no se usan lo suficiente. Así que para nosotros la calidad es uno de los componentes clave que tenemos que seguir fomentando en los servicios de atención, y no solamente en la atención integral, sino en todo lo que nosotros realizamos para abordar de manera exhaustiva el problema mundial de las drogas. Pues agradecemos nuevamente a todas y todos por su participación. Para mañana regístrense en nuestro evento que va a estar enfocado en la capacitación. En el chat ahí está el link para que ustedes se registren también en la actividad del día de mañana, donde estaremos nuevamente el doctor Luis Alfonso, que pues nos va a cobrar doble por su participación, pero bueno, ya veremos la manera de hacer esto posible. Y también estará con nosotros Uki Atkinson de Jamaica, y con gusto estaré con ustedes el día de mañana en el panel. Muchas gracias. Y Andrea, entonces...
Ahora sí digo muchas gracias nuevamente. Muchas gracias. Nada más, la sesión ha concluido. Gracias nuevamente a José Luis, y veo que siguen llegando los comentarios de los diferentes países. Gracias a todos por participar en esta sesión. Hasta mañana.